Good afternoon, and appreciate your presence in the late afternoon sessions of lovely city Kolkata. And I'm going to speak very basic, so if you are still in a postprandial stuff, remain there. It's nothing very new or exciting that I'm going to talk to you. This has no relevance, but has happened more than once to me, and this is what I mean. Everything is going well, and sometimes I don't focus well, my concentration is left, so sometimes even in spite of everything this happens, and the fact is it does happen. So it's very embarrassing, and then obviously the trick is to use the endocapsular ring, and that's not a big deal, but I realized having lost one ring, so I now learned, and particularly in my team, if anybody's putting ring, I ask them to put a 10 or nylon threaded into the eyelet so that at the end he will remove that and cut it. But in case if he has to sort of bring back from the well from behind, it's easy to retrieve this kind of endocapsular ring. So that's okay, but we were worried, we were embarrassed. Why did this happen? So we went back and we are reviewing our video of that same patient. What happened? Why did he get this zonulolysis? So we are reviewing our video, and suddenly the hydrodissection came, and the surgeon is just pushing it very gently on the surface and trying to remove, and see that? This was initiated because you were just swiping on the surface with the spatula from the side. So that's something make us think. So how does this spatula make this lens rotate? Well, it's not a rocket science. We know it for years, and I've learned from the faculty sitting here. You need to press, you need to go to the side, preferably 90 degrees, as away from the central axis than you can, at least 3 clock hours. Press downwards. Why? Because you want to use the posterior capsule and zonular support as a tempoline to support it on that posterior layer, and then rotate. And it will rotate if your hydrodissection really was subcapsular or corticocleaving. And this is what happens. If you really press and go 90 degrees, it will rotate very easily. So that's one thing we learned. Well, whatever you do, it doesn't rotate. The fact is, many times it doesn't rotate. The next step would be to rehydro it. Do not make it a stressful rotation. Don't do this. So to come out, no ego, it will take time. Inject dispersive viscoelastic a little bit, and then rehydro it in the area you're comfortable ergonomically. And I use and recommend this curved cannula, which is a copy of Dr. Akahoshi's cannula, and direct it toward the fornix. The standard teaching is that you tent the anterior capsule and lift up. It is okay logically, but it doesn't work many times. So if you instead introduce 1 mm at least beyond the anterior capsular axis and direct it and follow the curve of the lens. The curve of the lens is like this. Little down, not up, as I used to do. And it will invariably follow the slope and will produce a rotation. So that is something that I've learned over the years, and I try it. You may like it. So sometimes there are conditions called corticocapsular adhesions, and these are the adhesions. They are actually a kind of a cortical cataracts, and therefore occurs in a mature and cortical cataract. It doesn't occur in nuclear sclerosis, of course. And these superficial cortical cataracts are attached or adherent to the subsurface of the anterior capsule. And why they're important? Because they will resist the rotation, and if you do not make this egress of the water through that, you will have a problem. And also, if you try to suck it out before separating out, you produce what I did in the first case. So these are equatorial CCAs, and they are not thin. So if there is a resistance to the fluid wave transfusing, think about it and anticipate it preferably. And we found that it's useful in all kinds of cataract. In 2003, we did that with Dr. Apple and Jagat Ram and Liliana, the American journal, that the multi-quadrant hydrodissection is a good idea for various reasons, including PCO retardation, but here mechanical impact. So look for CCAs, avoid stressful rotation, proper understanding how you use these posterior capsules to support the nucleus and then rotate. Okay. Now, what I do now is not whatever I showed. What I do now is I'm going to show now. What I do now is I produce a good hydrodissection way, and if I'm satisfied, I do not attempt rotation, which was my rut, which was a default step. After hydro, I rotate. I don't do that. What I do now, and I want to produce a crack, whether I do sculpting or I do direct chop without any space, it doesn't matter, but I will rotate this lens only and only once I actually produce a crack. So this is a good way. I'm satisfied. So I'm doing a little trench, but I could have done direct, doesn't matter. The idea is to really produce a division, and mind you, the hydrodissection is good, so I'm not worried. And now what I'm doing is I'm using the principles of fulcrum and the long arm and the short arm. I will introduce the vertical element of the chopper as peripheral in the crack, in the groove as I can. And this is the center portion here. So we have a long arm here. The chopper will exert the force like this. So long arm, and you can understand, if I try to do it here with the short arm, I have to use more force. But if I do it over there, my force required is very minimal to direct the lens moving in this direction. So minimal force required for rotation. And I don't have to use this support of the posterior capsule and so on. So I recommend that if you're satisfied with your good wave, you know for sure you've separated it. Don't worry about it. Produce some kind of a space to introduce the chopper as peripheral as you can, and just with a little thing, it will rotate. So I find that very useful. It's gone? Or what's the time? It's over? 10 minutes? No. 7 minutes. So now this is a different thing altogether, and you can stop me, please, if you want. Now, notice that I'm doing this, whatever parameters, low parameters I use, but that's not an issue here. I'm doing that here. And this sub-incisional, what happened, and I think Rohit Om Prakash has also probably has alluded to some of these things, but it's so common, isn't it, that these small fragments come and sit on the side port through which you introduce chopper. So what I do, and it's so frustrating, and it will never come. You touch the endothelium and so on, and finally you manage that sort of thing. You know, you have to manipulate and things like that. So I'm really tired of this over the years. So what I do now, and I'm doing it for quite a while now, that if I come to a last fragment, I need this chopper to manipulate. So I want to have it, but not until the end. So as I come to a last one or two fragment, I will remove the chopper now. You will see me removing the chopper. And then I'm so easy. Why I'm doing it? Because there is no competing currents of water exiting through the side port. Because chopper is never snugly fitting. So I removed that competing current by just removing it. And every time, I never leave behind sub-incisional fragments. Sometimes it goes behind the iris, and we detect it later on. So this is the second tip that I wanted to share with you. And these are some other examples. I think with the time, I'll leave it. But remember, this is what I wanted to tell you. There is a competing current making these little fragments here underneath the side port. And aspiration flow rate is not that strong. Even if it is 30 or 35, it won't be strong. So instead, I found, and I'm so happy now, no embarrassment, and it eventually comes because I removed that exiting competing current. So thank you so very much.
Great tips, Dr. Abhay. Just a couple of questions. That endocapsular ring that you used, I saw there was quite a gap between the two eyelets. and I used to use that earlier. Rather, that was given to me. I used to use it. Sometimes once I place it, I used to find there is a large gap in adequate support. Nowadays, I use usually a 13 or a 13.5 millimeter with both the eyelets almost abetting each other, so that you get a all-round 360-degree support of the capsular bag.
I think it's a wonderful, and folks, if you are really listening to it, please order what you are using, and I will order it straight away. I never paid attention to that gap. So thank you for enlightening me on this issue, because I never thought it is, but I agree, there was a huge gap. Thank you.
And other question is, all of us have been talking about conventional horizontal chopping, vertical chopping. Horizontal, ideally we used to go right up to the equator and then chop vertical just in front of the phaco tip. But I think most of us are doing what we are doing now is hybrid chopping, something that I also saw you doing, where it's not very close, but essentially the movement is something like a horizontal chopping, but you move it towards the tip and then separate.
Yeah, I think the key is that ideal, from physics point of view, further you go away for chopping, put your chopper, say, around the equator, and do it, you will have to have a less force. But the reality is that how many times you can really go there comfortably, ergonomically. Even if you've done first crack, as you produce second, third, you find difficult to twist your hand and introduce the chopper under the rexes and so on. So you give up and you come closer away from the periphery. If you come away from the periphery, you need to combine a little bit of a vertical chop in situ, as I call it, vertical movement, and a little lateral rotation. But be safe, whatever. But from purely physics, further you go better. That's why the Nagahara was right in that. But in reality, we are not able to do it in every patient and not in every circumferential 360 degree. We give up finally after 2, 3, 4, and we switch on to this kind of hybrid or whatever you call it. So that is a wonderful thing. Thank you for bringing it up.
And lastly, I was intrigued by the fact when you said that you do hydrodissect but don't rotate your nucleus. Yes. I always do that because I think that breaks up the corticocapsular adhesions.
Yes.
And I don't proceed with introducing my phaco tip unless I have a free movement of the nucleus.
Yeah, actually, I agree what your concern. I can see your concern. What I mean is that I want to rotate surely before I rotate the nucleus. So do not rotate the nucleus before you actually do the rotation. So I do a space first where I don't rotate. The nucleus is still in situ. Hydrodissection is done, separated, and then I use this principle of less stress and rotate. But you have to rotate before you start rotating the nucleus for chopping or whatever technique you have. So I do rotate, and I believe rotation is mandatory. But I just push that back little. But if you push it back, make sure you don't rotate the nucleus. The nucleus has to be there. If you cannot produce a crack, don't do this. Thank you.
Thank you.